It is now my pleasure to introduce our first guest speaker for today's session, Dr. Akihiko Yoshida. He's attending pathologist and section head from Bone and Soft Tissues Pathology, Department of Diagnosis Pathology from National Cancer Center Hospital, Tokyo, Japan. He is a very well-recognized international expert in bone and soft tissues tumor and has contributed to many papers on his areas and also to many chapters on the WS Blue Books of Soft Tissues and Bone. So I have to say that I have two nice memories from my visit to Japan. One, the outstanding Sarcomas session led by Akihiko every morning with residents, and of course the excellent foods in the restaurant around the National Cancer Center. So please, Akihiko, could you share the screen if you don't mind and start your presentation? And thank you for your time.
Thank you, Isidro, for your kind introduction, and thank you everyone for inviting me to this exciting session. Can you hear me? Okay, good. So let me just share my slide. Let's see, how can I do it? Can you see the slide now? Yes. Okay, I'm going to the slideshow now. Okay, good. So today I'd like to share with you an interesting case that I had experienced several years ago. Okay, so here is an 18-year-old man with a right thigh mass. He noticed a slowly enlarging painless mass in the subcutaneous of the thigh for 2 years. After sarcoma diagnosis and biopsy, the tumor was widely resected without adjuvant therapy. On magnetic resonance imaging, the tumor showed iso-intense signal on T1 and heterogeneously high intensity on T2, which was not fat suppressed. Gadolinium enhancement was present. The surgical specimen showed a well-circumscribed 3.5 cm tan, soft, and glistening tumor. The surgical margin was negative, and there was no recurrence or metastasis at 5 years after the surgery. So microscopically, the tumor was lobulated by fibrous septa, and the cellularity was heterogeneous across areas. When you go higher in magnification, the tumor background was hyalinized to focally edematous, and the tumor showed a distinctive reticular growth pattern. Here is a representative area showing reticular growth of tumor cells within hyalinized background. On higher magnification, the constituent cells were oval to round and uniform in appearance with high NC ratio. One mitotic figure is depicted in the center of the field. Here's another view to show you the cytological details of the tumor cells. In some areas, the tumor demonstrated a cord-like growth pattern, which is very distinctive. Other areas demonstrated more hyalinized stroma with less cellularity. And occasionally, the tumor cells lined cleft-like spaces, which were reminiscent of interanastomosing vascular channels. Finally, we identified an extremely rare component of vacuolated cells in the tumor. So what is your diagnosis? So based on a characteristic corded or reticular growth pattern in an hyalinized stroma, the differential diagnoses that we originally included were entities that are shown here. Dense fibrosis and uniform cytology gave a similar appearance to solitary fibrous tumor. However, the tumor was negative for STAT6 by immunohistochemistry. Another differential was sclerosing epithelial fibrosarcoma. However, MUC4, which is a sensitive marker of SEF, was negative in this case. Sclerosing rhabdomyosarcoma is another close mimic. However, myogenin and MyoD1 were negative in this case, excluding that possibility. Although pretty rare in adolescent soft tissue, angiosarcoma was also in the differential, given occasional pseudovascular cleft-like architecture. However, vascular endothelial marker ERG and CD31 were both negative for this neoplasm. The only positive marker that we identified was a multifocal occasional reactivity to West100 protein, which is of course not really specific. And immunohistochemistry was only helpful in excluding some of the possibilities that we thought of, but was not very helpful in arriving at the diagnosis. So we went back to the H&E again to look for additional histological clues. Looking at the slides very carefully, we found that there were so many delicate capillaries in the center of the tumor tissue, like here. Because of massive hyalinization, the capillaries were somewhat obscured. However, when you start to look at them, they were numerous and everywhere, and show distinctive this branching pattern. In fact, dense sclerosis seems to be always surrounding the vessels. In addition, as we went through at the initial analysis, a few vacuolated cells were observed as shown here. Here are additional examples of rare vacuolated cells, which reminded us of lipoblasts. Because of vacuolated cells, delicate branching capillary pattern, and uniform cytological appearance, we suspected myxoid liposarcoma despite no myxoid matrix whatsoever. Prompted by H&E morphology, we performed FISH assays using FOS and DDIT3 break-apart probes, and we indeed found that most cells harbored break-apart signals in both assays, consistent with the presence of FOS-DDIT3 fusion. So the final diagnosis turned out to be myxoid liposarcoma with an extensive sclerosing pattern. Myxoid liposarcoma usually occurs in the deep soft tissues of young adults. However, up to 20% of the cases arise in the subcutis, like in the present case. Grossly, the tumor is well circumscribed, lobulated, glistening, and gray. Typical histology is that of proliferating uniform overcells that are randomly disposed within excessive myxoid stroma. The vessels are characterized by the delicate configuration and branching architecture. Lipoblasts are often present in the tumor, and most are in the form of signet ring cell type of lipoblasts. However, the presence of lipoblasts are not required for the diagnosis, as they can be absent, particularly in biopsy specimens. When myxoid stroma accumulates to form large pools, the stroma appearance may resemble pulmonary edema. And significant maturation can occur, usually status post-chemotherapy or radiation therapy. However, sometimes in treatment-naive examples. In this pattern, the tumor resembles lipoma or well-differentiated liposarcoma. Round cell component is a high-grade pattern of myxoid liposarcoma, and despite the name, round cell component is defined as hypercellularity, not as cytological roundness of the cells, although hypercellular tumors usually show round cells. Although no objective criteria for hypercellularity exist, the round cell component is usually recognized when the tumor cells touch each other. Here you can see the spectrum of cellularity in myxoid liposarcoma, and typically the rightmost panel is considered round cell pattern, whereas the middle panel represents a transition pattern that falls short of round cell criteria. The conventional round cell pattern consists of diffuse hypercellular proliferation of round cells that obscure underlying myxoid matrix or capillary architecture. Another known pattern is island-like morphology, in which highly cellular islands or archipelago of tumor tissues abruptly emerge from hypocellular background. Immunohistochemistry has played limited role in the diagnosis of myxoid liposarcoma. Although many cases are focally positive for S100 protein, this marker is not sensitive or specific enough to firmly support the diagnosis. And genetically, virtually all myxoid liposarcomas harbor specific fusion genes, including FUS-DDIT3 in more than 95% of cases, whereas alternative EWSR1 DDIT3 fusion in a small minority. The fusion can be detected by various methods, such as break-apart FISH assay as shown here. So going back to the present case of ours, the diagnostic challenge of this case mainly originated from perivascular massive sclerosis that obscured branching capillaries, only a small number of lipoblasts and virtually no myxoid stroma in this case. However, stromal sclerosis in myxoid liposarcoma has actually been documented in multiple papers in the past. Here you can see a figure of myxoid liposarcoma in the Ensinger and Weiss textbooks showing a distinct cord-like pattern, which looks almost identical to our case. In this very nice paper in AJCP by Dr. Fritchie, a cord-like pattern was clearly depicted too. And dated back to 1979 in AJSP, Dr. Evans already documented a hyalinized pattern of myxoid liposarcoma, which looks very similar to our example. One additional ancillary tool that has recently been introduced is a frequent DDIT3 overexpression in myxoid liposarcoma, reflecting the DDIT3 gene rearrangement of virtually all cases. In this excellent paper, all myxoid liposarcoma cases were positive for DDIT3 in the nucleus, and most mimics were negative, with a caveat that some dedifferentiated liposarcomas were positively labeled. So we tested the DDIT3 immunohistochemistry for the present case just for fun. And quite expectedly, it was diffusely positive, suggesting that this antibody could have been very helpful in the diagnosis if it were available at the time of original diagnosis. So in summary, we experienced a challenging case of myxoid liposarcoma with extensive fibrosis. Careful attention to the H&E morphology, including numerous branching capillaries, uniform overcells, and rare existence of lipoblasts led us to the correct diagnosis, fortunately. Demonstration of FUS-DDIT3 fusion by FISH supported the diagnosis. And I think this is a good case to share with you all for bringing attention to this very weird, somewhat under-recognized sclerosing pattern in myxoid liposarcoma, and also for highlighting the critical role of H&E morphology in conjunction with molecular findings to arrive at the correct diagnosis. Thank you very much, and I'm happy to take questions.
Thank you very much, Akihiko, for this nice presentation, an interesting case. Does anyone have any question or remarks? Akihiko,
Yes.
in grossly section for this tumor, did you find a sclerotic difficulty to cut the tumor, or they reveal myxoid appearance?
No, they are not really myxoid nor sclerotic or hard, or they just, I just showed in the first part of the talk, it looks just glistening and soft and gray, and it looks just, nondescript, and it looks just like a ordinary soft tissue tumors. I didn't even see any lipomatous component or, myxoid areas or anything. Yes.
Do you think that there was any previous case diagnosis at myoepithelial carcinoma, because before the era of NGAs, so we usually do fish, and so we can't find any case with prominent sclerotic stroma and focally X100 positivity, and it may be fit with myoepithelial carcinoma if you don't perform DDIT free.
Absolutely. I mean, the case that I presented looks very similar to myoepithelial tumors if taken out of context, because of this cord-like arrangement or reticular proliferation within a sclerotic background, which perfectly fits with the known characteristic histology of myoepithelial tumors. So in addition, the definition of myoepithelial tumors is somewhat subjective, and different people use a different criteria in terms of combination of immunohistochemical markers. Some say that the co-expression of keratin S100 is mandatory, and others say that EMA is good as a surrogate for epithelial differentiation, and S100 may be negative in a subset of cases. And so I'm pretty sure that before we have an easier access to the molecular diagnostics, many of the cases that were originally identified as a myoepithelial tumors turn out to be something else when looking at it more carefully using recent advancement of the immuno and molecular assays. Yes.
Okay, thank you. Just a moment, Professor John Barbosh, I'm afraid you are sharing your screen. We are seeing your screen.
Isidro, I had also a question for Dr. Yoshida.
Yes.
Well, I had a comment that I really like your case. Very, very nice and very difficult to recognize. So
Yes.
I wanted to know if you have seen this maturation phenomena in other tumors, because now I've got an angiosarcoma, and I was a little bit worried because just a little bit of the tumor was angiosarcoma, and then it has a kind of phenomena of maturation that it looks like vascular malformation or tumor. So is that possible to find after the neoadjuvant therapy?
Yeah, so the present case that provided today was not status post adjuvant neoadjuvant therapy, but I think the sclerosis can also occur after the neoadjuvant. And then, of course, the myxoid liposarcoma is well known to be sensitive for neoadjuvant therapy, including chemoradiations, so that the clinicians tend to put the patient under the neoadjuvant when the biopsy diagnosis was myxoid liposarcoma. So I agree with you that the sclerosis and the hyalinization may occur more commonly after the treatment. So that should be another pitfall. Yes.
And Professor Jumbar?
Dr. Yoshida, thank you very much for your very nice presentation. This is a very interesting case.
Thank
what
you.
About mitosis and the XII? Because the tumor, well, it is a malignant one, but it did not relapse, and it was not treated with chemotherapy or with radiotherapy at all, only surgery, even if the margins were free, of course. But let me know how was the mitosis number, because there has not been many mitosis seen in the slide, no?
I think it was about 2 to 3 per 10 hyperophils that are a bit higher than the usual myxoid liposarcoma. And also the cord-like arrangement is, it gives the touching of tumor cells with each other, so that it actually fits with the round cell definition as well, so that we called the tumor as round cell liposarcoma with cord-like pattern originally. So we are kind of suspecting that the tumor may recur or metastasize later. However, probably because the tumor was located superficially in the subcutaneous tissue and the tumor was small and noted earlier in the disease course, it was entirely excised with wide margin, and fortunately, patient is alive and doing well without any recurrence.
Thank you. Do you consider the existence of low and high grade myxoid liposarcomas? For instance, the round cell liposarcoma could be more aggressive than the myxoid or than the hyalinized one. Which is your feeling?
So I have only a few experience of the hyalinized myxoid liposarcoma. You know, this is the most hyalinized example that I experienced in the past. So that's why we showed it, you know, at this in this session. But I mean, the round cell to myxoid liposarcoma actually represent the continuum rather than a two distinct subset of a same tumor. So that if you draw an arbitrary line, for example, at the 5% cutoff, there will be statistically different survival, survival curves between the, high round cell and low round cell tumors. However, when you look at the individual case, showing you like 20% round cell or 5% round cell, it's very difficult to precisely predict the behavior of the myxoid liposarcoma based solely on the round cell component percentage.
Thank you very much, and congratulations.
Akihiko, are you able
Yes.
to read the chat?
Are we what?
To be able to see the chat box, because there is a question for you in the chat.
Oh, chat. Let me see.
Yeah.
Oh, there is. Let's see. Fantastic case and wonderful presentation. Thank you. How did I grade this case? So I graded this as a high grade round cell liposarcoma because of the, even if it is not a diffusely round cell tumor, it shows a closer approximation of the tumor cell. They are touching with each other. So like I said before, it fits with the round cell the definition of the round cell morphology. So I called it as a round cell liposarcoma, high-grade myxoid liposarcoma. Yes.
Thank you. Any further questions or remarks? So thank you very much, Akihiko, for the
Thank you very much, everyone.
And thank you for your time. So we continue with our second speaker, is Dr. Irene Low. She is consultant histopathologist at Middlemore Hospital, Auckland, New Zealand. Irene's areas of interest includes bone and soft tissue tumor pathology, breast and gynecological pathology, right? Thank you, Irene, for your time. I know you are on holidays and we appreciate your participation in this session. So please, could you share the screen if you don't mind and start your presentation? We can hear.
Right. I've just unmuted myself. That's a good start. Can you hear me all right?
Yes.
Thank you very much for your kind invitation. I'm going to share my screen. Let's just make sure that I've shared the right one. And right, hopefully you can see my front page.
Perfect.
So my name is Irene Low. I'm a pathologist at Middlemore Hospital, and together with my colleagues, we participate in a somewhat of a nationwide sarcoma service where we look after sarcoma patients in the upper half of the country, and there are four other pathologists that I work with, so a group of 5 of us together, and we participate in a regional multidisciplinary team regularly. So for today, I wanted to share a couple of cases with you. And as you can perhaps guess from my front page, the cases that I am going to share with you have multiple acronyms associated with these diagnoses. And I just wanted to use that as a way to perhaps discuss a slightly controversial topic about relationship between these various entities. The first case that I'm presenting is of a 59-year-old female who actually presented late last year. And so the follow-up detail that we have on this particular case is fairly limited. But nonetheless, she's well known to the rheumatologist with a inflammatory arthropathy. And in the process of being worked up for that, pointed out to the rheumatologist that she's had this enlarging bruise-like lesion of her anterior ankle over about 12 months. And that is the water-weighted MRI scan. You can see it has a rather sort of ill-defined edge about it, with a rather sort of edematous look to the lesion that's located on the anterior aspect of her right ankle. A low power impression is of a subcutaneous base, a lesion that is rather busy and infiltrating through fat. Slightly higher power, the tumor cells are fairly delicate fascicles that infiltrate amongst fat in a somewhat reminiscent of a DFSP type of manner. And you can probably appreciate at the corners of which slightly darker areas which represent hemosiderin deposition. Slightly high power of the same areas. For the most part, the tumor had fairly bland looking cytology with these delicate spindle cells infiltrating fat. In some areas, however, and this is, in the subsequent resection following the diagnosis made on the initial core biopsy, the resected specimen had much more cellular areas in which we noted significant cellular atypia with quite pleomorphic cells. There were indeed mitoses to be found up to 4 per 10 high power views without necrosis. And you hopefully would agree that there are some rather spectacularly pleomorphic cells that scattered throughout the tumor, with a sprinkling of background inflammatory cells and a few areas of hemosiderin deposition. And just one more higher power, just to impress upon you the atypia that's seen. And there's a suggestion that some of the cells are rather more plump and epithelioid, with multinucleated forms and rather large nucleoli. And fairly prominent throughout the tumor, we also see tumor cells that have intranuclear pseudo-inclusions. By immunohistochemistry, the tumor is diffusely positive for CD34 and negative for various other markers that we've examined for. And we also arranged for FISH studies, and it did not have a TGFBR3 gene rearrangement, much to our disappointment. It also did not have a PRDM10 rearrangement. So amongst the various differential diagnoses that we considered, we thought much of this tumor very much resembles a hemosiderotic fibrolipomatous tumor. And in areas where it's more cellular, we thought would raise the possibility of a sarcomatous progression. And we had elected to apply the name of a hybrid HFLT inflammatory fibroblastic sarcoma to this particular case, and that's potentially a slightly controversial name that could be up for debate, and I'm happy to entertain debate later. So a second case that I wanted to share with you is a slightly earlier case. This patient was originally living in Australia and had a long history of a multiply recurring tumor starting in 2001, recurred in 2004, and returned to New Zealand and recurred again in 2020. So what I've started showing you are the histology from 2020. As you can appreciate, there are some rather dilated vascular channels which contain fibrin thrombi, and around the vascular channels, there are rather mild hyalinization. The tumor is moderate to highly cellular, again, quite prominent hemosiderin deposition. At the periphery of this particular tumor, there are again these sort of highly infiltrative, delicate spindle cell fascicles that are infiltrating amongst fat, fairly similar to the first example that I shared with the areas of hemosiderin deposition, perhaps slightly more atypical in these infiltrative areas. We had the pleasure of reviewing the 2001 histology, which were made available in Sydney, where the patient was initially seen. The sort of presentation at the outset was of a highly infiltrative, delicate spindle cell pattern that infiltrates amongst fat. It was noted that there were quite prominent hyalinized vasculature and again, a background hemosiderin deposition and inflammation. The diagnosis that was made by the pathologist at Concord Hospital in 2001 was of a pleomorphic hyalinizing angiectatic tumor. And indeed, there were clusters of hyalinized vasculature seen scattered throughout. Coming back to 2020, when we were looking at the third recurrence of this patient's tumor, there are areas again that are markedly more cellular and more atypical, and we identified up to 6 mitoses in 10 high power views, Again, quite prominent intranuclear pseudoinclusions and rather marked nuclear pleomorphism are seen. And again, in the background of hemosiderin and scattered inflammatory cells and these sort of really hyalinized vasculature that were present from the outset. This particular tumor is again diffuse and strongly positive for CD34 with some multifocal weak positivity for Desmond and EMA and negative for a range of other markers that we examined. We did not have the TGR beta-3 FISH probe at the time in 2020, so we were unable to test it for that, but it did not have a PRDM10 rearrangement by FISH. So with this tumor, our diagnosis was of a hybrid hemosiderotic fibrolipomatous tumor with pleomorphic hyalinizing angiotatic tumor. Again, perhaps a slightly controversial name to apply to it. We also thought that given that the markedly cellular and atypical areas, that this probably is, the tumor is probably telling us that it's progressing towards a form of sarcoma. So I thought for the discussion part of my talk, I just wanted to briefly go through the various entities that have been linked together over the last 2 decades and have a little discussion about how these entities are related or perhaps not related. So as the title of my talk suggests, there is a lot of alphabet attached to these entities, so hemosiderotic fibrolipomatous tumor, HFLT and PHAT for pleomorphic hyalinizing angiotatic tumor, and myxoinflammatory fibroblastic sarcoma, which is abbreviated as MIFS, and hybrid forms thereof. Some of these have been clearly demonstrated to be related and others perhaps not so. Might be useful to go back into when these entities were first described and have a think about what the entities were suggested to be at the outset. So HFL2 was described not so long ago. The first description of it was in 2000 by Marshall Taylor and Fanbert Smith. And at the time, they considered it as a reactive process and thought that most of their patients had an antecedent trauma and named the entity hemosiderotic fibrohistiocytic lipomatous lesion rather than the tumor. And you can see from the original illustrations in their paper, the very characteristic delicate sort of infiltrative pattern through fat of these spindle cells. Of note, they had described in the original series that there were a little bit of atypia and some rather larger pleomorphic cells, but those are not a predominant feature. And very much the characteristic appearance of this tumor is of spindle cells infiltrating amongst fat, and there's a background hemosiderin, which gave its name hemosiderotic fibrolipomatous tumor. In 2006, Dr. Fletcher and his colleague, Dr. Brown, formally reclassified it as a neoplastic process, largely on the basis that the lesion that were described as HFFL did seem to have a very high propensity for local recurrence. Somewhere between 50 and 60% of cases are known to locally recur, but essentially non-metastasizing. And so they introduced the term hemosiderotic fibrolipomatous tumor, which is now the accepted terminology in the WHO book. Again, a very intimate admixture of fat and bland fibroblastic cells and multinucleated giant cells and hemosiderin. So generally, we accept that it has a very marked predilection for subcutaneous tissue of particularly the distal lower extremity leg and ankle region, a slight predominance in the female more than male patient, consistently a CD34 positivity, and a significant subset is now shown to harbor rearrangement of TGF beta receptor 3 and or MGA5 genes, and we'll come back to that a little bit later. There's a very high propensity for local recurrence, and sarcomatous transformation is said to be very rare. What about pleomorphic hyalinizing angiotatic tumors? So this is slightly earlier in its description in 1996 by Dr. Smith, Fisher, and Weiss, who described a small series of cases in which the tumor is predominantly characterized by rather prominent ectatic fibrin-containing vessels with prominent circumferential hyalinization and spindled and pleomorphic stromal cells that have quite notable intranuclear pseudo-inclusions, but of note, it has very few to no mitotic activity. There's often a variable hemosiderin deposition as well as a inflammatory component to the lesion. Even though it was named as a pleomorphic hyalonizing agitatic tumor in 1996, and at the time it was thought to be largely predominated by the vasculature. When you go back and look at the original images that are shown of the lesion, it indeed has a rather prominent infiltrative component at the peripheral of it. The resemblance of this peripheral component was very much highlighted by Dr. Folber, who co-wrote a paper in 2004 with Professor Weiss, suggesting that the periphery of what they had described as a PHAT in the infiltrative edges of the tumor, it showed features that are very closely resembling what had subsequently been described as HFLT, characterized by bland hemosideronated spindle cells that infiltrate fat and surround the vascular aggregates. This, however, was a slightly controversial and perhaps not universally accepted stance, as subsequent papers had consistently accepted the relationship between HFLT and PHAT. However, if you look at the sort of the clinical pathological characteristics of PHAT, it's very much similar to what one sees in HFLT. It's a predilection for subcutaneous tissue at the lower extremity, middle-aged adults, slight female predominance more so than male, and consistent CD34 positivity in a substantial majority of the tumor. Again, a subset has now been shown to harbor the same gene rearrangement as seen in HFLT. Very high propensity for local recurrence and rare sarcomatous transformation is reported. So what about mixed inflammatory fibroblastic sarcoma? This entity was described in 1998 by 3 separate groups, which gave it 3 separate names, but it was apparent that the 3 groups were concurrently describing essentially the same entity that is now termed mixed inflammatory fibroblastic sarcoma in the current WHO classification. It's a rather more lobulated lesion, typically with the myxoid areas that are formed distinct lobules with the spindled and epithelioid cells. And the notable features that were remarked on at the outset were these large tumor cells that have a varicose-like or Reed-Sternberg-like really pronounced nucleoli. And these are some lovely pictures that I borrowed from Dr. Lucas's review paper from Archives 2017. There's often a predominance of inflammatory cells in the background. The cells are rather more ovoid to epithelioid compared to the examples of hemosiderotic fibrolipomas tumors that I've just shown. And if you look at the clinical pathological sort of characteristics of this particular lesion, although it does have a predilection for dorsal acral location, it has also been reported at other sites that are not acral related, typically subcutaneous, but commonly involves a deeper site, including intramuscular and tendon involvement, not so much of a sex predilection, so both males and females equally gets it. It does not have a particularly specific immunohistochemistry, although CD34 is quite often positive. Subsets of this particular tumor has also been described to show arrangement, and as well as other genetic aberrations, particularly VGL-L3 amplification and a small subset with BRAF gene rearrangement. This particular tumor has a high propensity for local recurrence as well, but does have a metastatic potential of somewhere between 2 to 5%, depending on the series that you read. Which then brings us to this question: are these 3 entities related, or are they in fact completely separate? There were various studies between 2009 to 2011 looking at the genetic aberration that were first described in a case of mixed inflammatory fibroblastic sarcoma of a consistent translocation between chromosome 1 and chromosome 10. And the gene that the chromosomes mapped to TGF-BR3 and MGF5 were known about in 2009 by the Swedish group. And in their paper, they identified 4 cases of mixed inflammatory fibroblastic sarcoma, or cases that they've diagnosed as MIFS that indeed had this T110 translocation. Subsequently, Christina Antonescu and Professor Fletcher's group has further studied this and also came to the conclusion that in both mixed inflammatory fibroblastic sarcoma as well as hemosiderotic fibrolipomas tumor, in their study, a significant proportion of those, upwards of 80%, had this consistent gene rearrangement. And a further paper in 2014 by Andrew Forbes' group further elaborated the presence of these gene rearrangements in pleomorphic hyalinizer angiotatic tumor. So if you take all of these 3 papers together, it might suggest that these 3 entities potentially are close cousins of each other. However, subsequent to the initial papers, several further studies, mostly led by Professor Andrew Forbes, has suggested that, in fact, if you tease apart the entities that were studied, if you look at pure myxo-inflammatory fibroblastic sarcomas as they are classically described and examined for gene rearrangements in those, they are much less likely to harbor TGF-BR3 or MGA5 gene rearrangements. In fact, only about 5% of these pure MIFS cases are said to harbor gene rearrangement. And where you do see these gene rearrangements, however, is much more common in cases that were considered to be so-called hybrid hemosiderotic fibrolipomatous tumor with mixed inflammatory fibroblastic sarcoma, as well as typical examples of HFLT. And out of the cases, only 2 out of 31 classic mixed inflammatory fibroblastic sarcoma harbored these gene rearrangements in MGA5. And in fact, all of them lacked TGF beta receptor 3 rearrangements. Further studies specifically looking at MIFS has also confirmed these findings that, in fact, if you took the MIFS diagnoses that are prospectively diagnosed on morphological grounds and examined for TGF beta 3 receptor gene rearrangements, there are very much a minority of cases that shows the rearrangement. Instead, there seems to be a recurrent BRAF gene rearrangements that's now being described in MIFS, which is not described in HFLTs. A very nice review paper by Dr. Forbes and Dr. Boland further elaborated on their thoughts on how these entities are related or not. And in 2017, at least, up to 73% of cases of HFLT that were studied had the consistent gene rearrangement, 47% of PHAT, and only about 18% of MIFS had the gene rearrangement. And in their paper, they alluded to the fact that perhaps the differences in the propensity for MIFS to show the gene rearrangement might relate to lack of consistent criteria and how one diagnoses mixed inflammatory fibroblastic sarcomas and which specific criteria you use. And it seems to be that if you took the original sets of cases and applied the morphologic criteria strictly, the possibility of them being related becomes much lower as at least from the genetic standpoint. Just for your interest, a summary of the key morphologic features that are in Dr. Forbes' review paper. That's quite a good reference to go back to. So in conclusion, it seems from the current literature, at least, that HFLT and PHAT indeed belong to the same spectrum of disease and probably not as closely related to MIFS as initially thought. When you get malignant transformation of a HFLT, PHAT spectrum of disease, it typically occurs in the form of a myxoid sarcoma, although I noted there's recently been a paper published with a high-grade transformation that resembled SMARCA4 deficient sarcoma that behaved in a much more aggressive fashion. But typically, the small number of cases of malignant HFLT that's been described are largely in the form of a low-grade myxoid sarcoma that variably resembles myxo-inflammatory fibroblastic sarcoma, but probably not truly related to classic MIFS. And if you took a classic MIFS per se, they infrequently show the TGF beta R, the receptor 3 gene rearrangement, and indeed a subset of cases would harbor alternative genetic alterations such as BRAF fusions. I think that might be my last slide, just as in conclusion, a last slide to show you what the South Island of New Zealand looks like. That's a picture of Mount Cook from a hike that we had recently. Thank you very much. I'm be grateful for any comments and happy to answer any questions.
Thank you very much, Irene, for this nice presentation and the discussion about these entities. So does anyone have a question, remarks? Akihiko, please.
No, I was just clapping. It was a great, presentation and trying to give some order into this somewhat disordered nomenclature of a variety of diseases. Thank you for your presentation. I enjoyed it very much.
Thank you. Can I just ask Dr. Yoshida, do you use the hybrid HFLT MIFS terminology?
Yes, I do. Yes, HFLT and FAT, PHAT nomenclature. I use it sometimes because we sometimes see it at the periphery, like Dr. Fulp suggested. There is occasional areas very much resembling HFLT at the periphery of HFAT, PHAT, I would say. However, the MIFS diagnosis is sometimes very difficult to make based on biopsy because ordinary mixed fibrosarcoma sometimes looks very much similar to MIFS, and the original emphasis on inflammatory infiltrate or hyalinization or pseudo lipoblast, virussite-like nucleoli are all very non-specific in my opinion, and they can be also seen in mixed fibrosarcoma, which could be very high grade. I have made a few mistakes on biopsy in which I called one case or two MIFS, which turned out to be a high-grade sarcoma that ended up with metastasis. So I had a very bitter memory of this MIFS concept, and I tried to be very careful before calling it as outright MIFS, particularly on biopsy. Yeah.
Sure. We sometimes have disagreement amongst our group about what constitutes high-grade MIFS and what is essentially just high-grade mixed fibrosarcoma, and that sometimes is not a particularly easy thing to sort out other than one person's opinion over another, essentially.
Absolutely. When you include the high-grade variant, if there is such a thing into the MIFS concept, then the distinction between MIFS and mixed fibrosarcoma will be clinically irrelevant because they all will be treated similarly. The value of creating an initial concept of MIFS was the low gradeness, that of the MIFS that prompted the different treatment from mixed fibrosarcoma from a clinical perspective. So
sure, thank you.
May I ask
You're
a
welcome.
question? I have a question now.
Yes.
Can I? Thank you. In our hospital, we had a recent case of a clear hemosiderotic fibrolipomatous tumor, but when the surgical incision was done, around 40% of the tumor was myxoid, but with few, very, very few really pleomorphic cells, like 3-4 scattered cells. And I was in that. If I have to consider that as a myxoid sarcoma over a fibrolipomatous hemosiderotic tumor, or it was just part of the spectrum of the lesion, because it was not really a typical. Do you have any idea of?
I think if you go back to the original literature that described HFLT, the initial morphologic description of the entities allowed for small numbers of pleomorphic cells. And if you draw the parallel and sort of believe the idea that HFLT and PHAT are close cousins of each other, then I would have thought that you would have to accept pleomorphic cells in the absence of significant mitotic activity or other, hypercellularity or necrosis or other aggressive morphologically worrisome features. If it's just on the basis of small numbers of atypical cells, I would have thought that HFLT is still where one would park it, or at least that would be how I would view your case. So what did you actually call it?
I call it hemocytic fibrolipomatous tumor, but I add
I think that sounds very fair to me.
Comment saying there's more myxoid areas than I was expecting, and these tumors can degenerate in myxoid sarcomas. So be careful. Yeah, just not saying. I have no criteria for calling that a sarcoma, and be careful. But I was really new because I didn't know exactly what to do. And I have another question. In the rearrangements you were talking that are present in fat and in the fibrolipomatous hemocytic tumor, I have read that they are in the DNA, but they are not translated to the RNA. So you cannot detect them by next generation sequencing strategies based on RNA. But it's sometimes confusing because in some papers that's written, but in others not. Do you have any experience on that?
I don't have any personal experience. We are largely limited to performing FISH tests from a diagnostic point of view. But I do know that I think in 2019, there was a single case report using RNA-seq that identified the counterpart of so not the TGFBR3 arm of it, but the MGF5 arm of it. In actual fact, that particular gene, the RNA-seq had picked up a closely related but slightly differently situated and differently named gene. I'm sorry, I don't remember the name of that alternative gene, but it was a single case report that did identify through RNA-seq the appropriate gene. But I don't have any personal experience in that sense. I don't know whether anybody else has.
Okay, thank you very much.
Thank you.
And Irene, I have a question. Thinking in NGS, do you think it's mandatory to perform NGS to detect specific gene fusion in this tumor when the morphological pattern is clear? Or this provides any prognosis significant in this tumor, or does it only for just in case that there is a sarcomatous transformation you want to demonstrate that it was arising in those tumors?
Sure. I mean, I think knowing about the genetic alterations for me is intellectually interesting. I'm not sure that it is therapeutically or sort of clinically that useful at this point in time. In my experience, the cases that are recognizable for hemocirrhotic fibrolipomatous tumor are quite characteristic. So you look at them and you already have an inkling that that's what you're diagnosing, and then one goes to look for worse areas. And as we were talking about earlier, the distinction between what is just HFLT and what is sarcomatous transformation may sometimes be not so clear. I suppose if you had something that is that you're classifying as a myxoid sarcoma of sorts that has some resemblance to myxoinflammatory fibroblastic sarcoma, but not perfectly so, and you were to have access to TGFBR3 FISH studies, for an example, or have an ability to look for it, and it was a positive result, that might lead you to at least propose that perhaps your myxoid sarcoma had its origin as an HFLT PHAT spectrum of tumor. I think that's probably where I think it would be useful. But otherwise, I think morphologically, if you were already thinking that it looks like HFLT, I'm not sure that there is great value beyond intellectual understanding to do the test.
Okay, thank you. Any further questions or remarks?
Yes, I have just one quick question. Thanks for the presentation. A question about cyclin D1 immunohistochemistry has been said to be not specific but consistently positive in this myxoinflammatory fibroblastic sarcoma, together with the emperipolesis. If you don't see emperipolesis, the suggestion is think of something else. What's your experience in what would this be useful in the differential?
I find cyclin D1 not specifically useful. I think if you were already going to call a myxo-inflammatory fibroblastic sarcoma and you went to look for emperipolesis and you saw it, you thought, hey, that's great, it supports the diagnosis. And then if you were doing cyclin D1 and it was not positive, that's not going to stop me from calling it. And if it was positive, I'm happy that it supports it.
Okay.
And likewise, if I were to call something, hypothetically speaking, a malignant sort of hemosiderotic fibrolapinerous tumor that has MIFS-like areas, I have no experience what cyclin D1 would do in them. But in either case, I'm not sure that that would sway me anymore about whether the cyclin D1 would make it more or less likely to be myxo-inflammatory fibroblastic sarcoma. So I personally, in our group, there are various pathologists who look at the same case, so we often contribute to the immunohistochemical workup. And so I tend to see the cyclin D1 staining characteristics because another colleague had asked for it, not because I personally found it to be that useful. So I kind of look at it with interest, but not particularly find it useful from a diagnostic sense.
Thank you.
No problem.
Thank you, Irene, for the time, for the presentation. We enjoyed pretty much. We continue to our first speaker. That is Dr. Daniel Wong. He is consultant pathology from Perth, XII Medical Center, Perth, Western Australia, senior clinical lecturer, School of Medicine from the University of Western Australia. He is also a very well-recognized international expert in bone and soft tissue tumor and have contributed to many papers on this area. So Daniel, thank you very much for your participation. And please, could you share your screen if you don't mind?
Okay, how's that? Can you see my screen now?
Yes.
Okay. Thank you, Dr. Machado, for the invitation to present at this session. So I've titled my talk for today, Myogenic Tumor Resisting Classification, for reasons that hopefully will become clear to you as I go through this case. So this is a 65-year-old male who had a history of peripheral vascular disease and was having an angiogram and had a mass incidentally discovered in his right lower leg. And so here we see the mass, which measures about 25 millimeters across. You can see that it's quite well circumscribed. It's also got some spotty calcification, and it's closely opposed to the tibial cortex without any bone erosion. On MRI, the mass is entirely situated within the tibialis anterior muscle. It's got a slightly increased signal on T1 weighted sequences. I haven't shown you the T2 sequences here, but that was also mildly increased. And there's fairly homogeneous post-contrast enhancement. And because of the calcifications, our radiologists here offered a diagnosis of either synovial sarcoma, a hemangioma with calcified phleboliths, and because of its location on the surface of a long bone, they also suggested perhaps parosteal osteosarcoma. On PET scan, the mass showed mild to moderate FDG avidity, but there was no evidence of any avid loco-regional or distant metastatic disease. And so a percutaneous core biopsy was done, and here we see a cellular tumor composed of plump spindle cells in these loose fascicles set on a mildly fibrous background. There was spotty calcification, just like we saw on the CT scan. And for the most part, the cells were very bland in appearance, very uniform nuclei, but there were also some focal areas of increased cellular pleomorphism, where the cells showed nuclear enlargement and hyperchromasia. You can also see the deep eosinophilic cytoplasm, but there were no cross striations like you would see in rhabdomyoblastic cells. Mitoses were not readily identified in this, and there was no necrosis. With immunohistochemistry, the cells labeled very strongly and diffusely for Desmond and MyoD1, and there was some multifocal staining for myogenin, but no staining for heavy Cal-Desmon. And so given that this is good evidence of a skeletal muscle line of differentiation, and given the cellular pleomorphism, we favor the diagnosis of rhabdomyosarcoma on the core biopsy, although there was some debate within our group here as to whether this was more like spindle cell or pleomorphic RMS. Normally, here in Perth, our oncologists would treat this tumor with a preoperative diagnosis of rhabdomyosarcoma with chemotherapy. So the standard of care here is to give neoadjuvant chemotherapy for rhabdomyosarcoma. But given the fact that this was a small tumor and this was isolated disease, the surgeons decided that they would proceed immediately to primary resection. And as you will see, based on the final diagnosis, as pathologists, we were very grateful for that. And so you can see here the tumor is within skeletal muscle. It's very small and well circumscribed, and it's lobulated. And it also has a homogeneous pale white fibrous appearance. There's no necrosis, no hemorrhage or cystic change. And the surgeon tells me that this was very easily separated from the tibial cortex. Down the microscope, it's again very well circumscribed. It's even got a fibrous pseudocapsule, and it's a very cellular tumor. We can see large areas of dystrophic calcification, just like we saw on the core biopsy and also on the CT scan. And within the capsule, there was a mild and patchy lymphocytic inflammatory infiltrate, often forming lymphoid aggregates. For the most part, the spindle cells were quite bland in appearance, forming loose storiform patterns within this fibrous background with some scattered compressed capillaries. In some areas, you could just make out some histiocytes mixed in with the spindle cells. And just like we saw on the core biopsy, there were some multifocal areas of increased cellular pleomorphism with larger and more hyperchromatic nuclei and quite prominent multinucleation. Some cells had a rhabdoid quality to them with deep eosinophilic cytoplasm, but once again, no well-defined cross striations like we would expect in a mature rhabdomyoblastic cell. And despite the pleomorphism, mitoses were virtually absent in this tumor, no more than 1 per 50 consecutive high power fields, and there was no necrosis. The immunoprofile was the same as what we saw on the core: diffuse Desmond and MyD1 staining, more isolated staining for myogenin, and CD163 really highlighted the abundance of histiocytes within the background. PHH3 confirmed the virtual absence of mitotic activity, and this correlated to a low Ki67 proliferation index of about 1%. And so given the small size of the tumor and the virtual absence of mitotic activity, there was a real reluctance here to call this rhabdomyosarcoma again. And so after going through the literature, we feel that the features here overall are consistent with a relatively newly described entity, which is at the moment being called inflammatory rhabdomyoblastic tumor. So inflammatory rhabdomyoblastic tumor, or IRT, was first described by Dr. Fulp and Dr. Martinez and colleagues about 4 years ago in a paper in Modern Pathology, where they described 10 tumors which they originally described or termed histiocyte-rich rhabdomyoblastic tumor. More recently, they've changed the name to inflammatory rhabdomyoblastic tumor, which I think is a better name for it because sometimes the histiocytes aren't that obvious morphologically. And also the inflammation is mixed. It's not just histiocytes, you almost always see lymphocytes as well, and perhaps a few plasma cells. So at the moment, there are about 30 of these cases reported in the literature. And based on this tumor appears to affect young to middle-aged adults with a median of about 37 years. There is quite a strong male predisposition with a ratio of 4:1. And the classical history is of a slow-growing mass that develops over years in deep soft tissue, especially within the extremities. And the thigh is the most common location, followed by the trunk, arms, and neck. and there are some isolated cases reported in visceral organs. Based on a median follow-up of 9 months, which admittedly isn't that long, but that's from the largest series of this tumor seems to have a very good prognosis. There's only a single case reported with intra-abdominal spread, and there are no cases reported of distant metastases, although there is a caveat to that, and I'm going to come back to that at the end of the talk. So these are some pictures from Dr. Fobb's original paper, and you can see the similarities to the case I've just shown you. So the key features that we're looking for here is a circumscribed tumor, often with a fibrous pseudocapsule. It is allowed to have microscopic areas of infiltration, but this should be to a limited extent into the surrounding stroma. Calcifications is quite characteristic, and as the name suggests, this has an inflammatory-rich background, which is dominated by histiocytes and lymphocytes. The spindle cells have a myeloid quality to them, so they often show glassy eosinophilic cytoplasm, but you don't see cross-striations like you see in mature rhabdomyoblastic cells. And the cells are variably pleomorphic. But one of the key features of this tumor is the paucity of mitoses. You really shouldn't be seeing mitoses more frequently than 1 to 2 per 50 high power fields, and there is no necrosis. So this tumor labels strongly for Desmond, PAX7, and MyoD1, and that suggests that it has an immature or primitive skeletal muscle phenotype. Transcription factors that are involved in the terminal differentiation of skeletal muscle, like myogenin, are expressed less diffusely. And so that fits in with what we're seeing histologically, this idea that we don't really see well-developed rhabdomyoblastic cells microscopically. If you use histiocytic markers like CD68 and CD163, that can be useful to disclose that histiocyte-rich inflammatory background. Keratins S100 and SOX10 are negative, and some groups have looked at whether FOXO1 fusions can be found in this, like we would see in alveolar rhabdomyosarcoma, and that's negative. There's no MYD1 mutation like we would see in many adult cases of sclerosing and spindle cell rhabdomyosarcoma. And people have also shown that there's no EWS1 or fuzz rearrangement, as we would see pairing with TFCP2 in some cases of adult intraosseous rhabdomyosarcomas, which are very aggressive. So I guess when we consider this entity, there are a few questions that we might ask ourselves. Firstly, why is this not an unusual pattern of rhabdomyosarcoma? So as I'm sure you all know, the current classification of RMS recognizes 4 subtypes. So there is embryonal, alveolar, pleomorphic, and spindle cell sclerosing. The first 3 are very easy to separate because their histological features are really quite dissimilar to IRT. So for example, in embryonal RMS, we typically see a myxoid stroma. Mitoses are very frequent and there's often necrosis. We see distinct growth patterns like perivascular cellular condensation or cambium layer if it's occurring in an epithelial line organ. In the case of alveolar RMS, this is a typical small round blue cell tumor, which shows a pseudoalveolar growth pattern. And in the case of pleomorphic RMS, these are large tumors that are infiltrative. They show diffuse pleomorphism, brisk mitotic activity, and necrosis. So those first 3 are clearly quite different from what we're seeing in IRT. Spindle cell RMS is a little bit more tricky because here there is a bit of histological overlap with IRT, but it is distinguished by being more mitotically active. It often doesn't have prominent inflammation, and it often demonstrates MYD1 mutations, as we know, in about 50% of adult cases of spindle cell sclerosing RMS, whereas in the infantile group, they often show fusions that involve NCOA2, pairing with other genes like VGLL. I guess another question that we could ask ourselves is, if it's not rhabdomyosarcoma, then why is this not an unusual type of a rhabdomyoma instead? And here we recognize 3 types of rhabdomyomas. There's adult, fetal, and genital types. The clinical presentation of rhabdomyomas, as you know, is quite reproducible. Adult and fetal type rhabdomyomas typically occur in the head and neck region, whereas genital types of rhabdomyomas, as the name implies, occur at genital sites. And these are uncommon sites for us to see IRT. Histologically, they're different too. Adult type rhabdomyomas are composed of sheets of large rhabdoid cells and spider cells, whereas the fetal type and genital types of rhabdomyoma often show terminally differentiated skeletal muscle cells. So we see good going rhabdomyoblastic cells with easily identified cross striations. And these are not features that are typical of IRT. More recently, there's been some very interesting work whereby some people have made the very clever observation that IRT seems to have a lot in common with inflammatory leiomyosarcoma. And in fact, in some cases, the features are completely identical. So as you all know, inflammatory leiomyosarcoma, ironically, was only recently introduced as a discrete entity in the most recent WHO classification, where it is defined as a sarcoma showing smooth muscle differentiation, a prominent inflammatory infiltrate, and it has a very classical genomic profile where there is near haplodization. And so what that means is that there is loss of one copy of a chromosome across the entire genome, but typically sparing chromosomes 5, 20, and 22. Less commonly, you can also see mutations of NF1 superimposed on this. And so you can see that histologically, there are a lot of similarities to IRT. Once again, we see spindle cells on a lymphohistiocytic rich inflammatory background. And so when people have gone back and studied cases of IRT at a genomic level, they find that the profile is exactly the same as inflammatory leiomyosarcoma. Once again, you get the near haplodization with retained parental disomy of chromosomes 5 and 22. And in fact, there are even a handful of cases of IRT that show NF1 mutations, including one patient with neurofibromatosis type 1. Even more interestingly is that some authors have gone back and taken cases of apparent inflammatory leiomyosarcoma and shown that if you use specific markers of smooth muscle differentiation like heavy desmon, these tumors in fact don't stain positively at all. And what they do stain with are skeletal muscle markers like MyD1, myGenin, and PAX7. And so I guess we should be asking then, how did the original authors who proposed inflammatory leiomyosarcoma, what led them to consider these to be smooth muscle tumors in the first place? And so what you find when you go to the original literature, some of which goes back to the mid-1990s or late 1990s, is that at that time, the investigators were using muscle markers that weren't entirely specific. They were using desmin, smooth muscle actin, and panactin. And we know today that these markers are not specific for smooth muscle. They can be seen in skeletal muscle tumors, and they can even be seen in non-myogenic tumors. You do come across more recent papers like this one from 2020 that talks about inflammatory leiomyosarcoma expressing desmin. But when you read the fine print, you realize that they're using a non-specific clone, for example, the E89 clone. And that E89 clone actually has very low specificity for smooth muscle differentiation. In one study, the specificity was less than 10% compared to heavy desmon, which is nearly 100%. And so when you use that more specific antibody, you realize that these apparent inflammatory leiomyosarcomas in fact don't stain for this newer marker. Some other authors have also looked at gene expression profiling in inflammatory leiomyosarcoma and shown that these tumors in fact upregulate genes associated with skeletal muscle differentiation and not smooth muscle differentiation. And so I think at the present time, there is very good evidence that cases of so-called inflammatory leiomyosarcoma are probably not true smooth muscle tumors, and that they probably represent the same entity that we're currently calling inflammatory rhabdomyoblastic tumor. There was a paper recently that talked about using fish as a surrogate test for demonstrating near haplodization. So if you don't have access to array CGH or SNP arrays, you can use fish as a surrogate test. And we did this in the case that I've just presented. So we used fish directed against, using probes directed against a number of genes located on different chromosomes. So we used the probe directed against centromere 10, against EGFR and centromere 7, and NCOA2 on chromosome 8. And we were able to demonstrate that there is very good evidence of monosomy of all of these genes, implying that there is this near haplodization. And when we use a probe directed against a gene on chromosome 22, like SMARCB1, there is retained disomy, fitting in with that original genomic profile. Having said that, it is important to stress that at the moment, the diagnosis of IRT is a morphological and immunohistochemical diagnosis. You don't need to demonstrate the near haplodization because in some cases it's not present. And they found that those that do have it and those that don't have the near haplodization, they seem to behave in exactly the same way. So it is a little bit academic at the moment to demonstrate that. One question that I had when I came across this entity is, well, in that case, do inflammatory leiomyosarcomas exist at all? And the answer to that is still evolving. So if we see, this is a paper that was published earlier this year that described inflammatory leiomyosarcomas within the lung. So these are tumors that are truly smooth muscle. They don't show any skeletal muscle differentiation. They're also indolent tumors like the original description of inflammatory leiomyosarcoma, but they have a diploid genome. So it is slightly different to what is being described in the WHO. As to whether or not these also exist outside the lung, I don't think anyone really knows that at the moment. I think more study probably needs to be done to be sure. And then just to finish off, I just wanted to put in a caveat that even though IRT seems to have a very good prognosis, there is a case report of IRT progressing to high-grade sarcoma. And so this was a 42-year-old male who had an 18-centimeter left thigh mass, and he had an incisional biopsy done. And a large part of the biopsy showed features identical to IRT, but then there were other areas that had progression to established high-grade sarcoma with frank pleomorphism, brisk mitotic activity, and necrosis. And interestingly, when they micro-dissected out these areas, they showed that the areas of conventional IRT had the classical near haplodization, whereas the areas of high-grade sarcoma showed the near haplodization, but there was superimposed complexity with increased copy number gains and losses. And that tumor behaved very aggressively. The patient suffered soft tissue, lung, and bone metastases and died of their disease 4 months after diagnosis. And so in summary, inflammatory rhabdomyoblastic tumor is a rare tumor which classically occurs in young to middle-aged adults, particularly males. It's a slow-growing tumor in deep soft tissue. Histologically, it's a circumscribed inflammatory rich spindle cell tumor, and it has rare mitotic activity. By immunohistochemistry, it shows an established rhabdomyoblastic line of differentiation, and at a genomic level, it shows near haplodization, and all of these features seem to be identical to so-called inflammatory leiomyosarcoma, which at the moment appears to be not a true smooth muscle tumor at all. And IRT is a borderline malignant potential tumor with the caveat that some rare cases can transform to high-grade sarcoma. And so just to quickly say thanks to my colleagues who work with me here at Pathwest in Perth, and I'm happy to take any comments or questions if anyone has any.
Thank you very much, Daniel, for your nice presentation regarding this tumor. So I have a question. As you presented in your case, there was some tertiary lymphoid structure in the periphery of the tumor. These recently have been related to very good prognosis in a new French classification of lymphoid infiltration in sarcoma tumor. And they have proposed that sarcoma or mesenchymal lesion with many tertiary lymphoid structure may have better prognosis. It could be related, it could be fixed with this kind of rhabdomyoblastic with inflammatory matter.
Yeah, no, it's a good question. I've also heard about this as well, and I think correct me if I'm wrong, but I think some people have also started talking about whether checkpoint inhibitors might be effective in that setting if it's inflammatory reach.
Yes.
This one, I mean, I guess the interesting thing about the distribution of the lymphocytes in this tumor is that they're largely peripheral. They're not truly tumor infiltrating as such. And so whether that is the explanation for the mechanism, I'm not sure. I suspect the low mitotic activity has a large part to do with this. Something must be holding this tumor back from proliferating. And I suspect that has more to do with the good prognosis. But yeah, no, it is an interesting observation. And I think that the papers that talk about this tumor, one of the differentials that often comes up morphologically is to separate it from angiomatoid fibrous histiocytoma. And so that's to emphasize this idea that the lymphoid stroma is often at the periphery. It's like a cuff, like you see in angiomatoid fibrous histiocytoma. But yeah, no, it's an interesting point.
I had a question, Dr. Wong, a very nice case and very difficult. And could you see the zonation in the distribution of the cells? So like, because of the calcification that looks like, obviously not but similar to the ossifying myositis because of the inflammatory nature, or no, it is all the same?
Yeah, sure. Yep. So the calcifications in our case were largely peripheral in the capsule, but there was some in the center too. And the papers that have been written on this emphasize that, yeah, the calcifications can be within the tumor. In terms of zonation, it doesn't show a nice zonation like you see, for example, in like in myositis ossificans, for example. But there is definitely a geographical distribution of the pleomorphic cells. So for the most part, the cells are very, very bland. But where you see increased pleomorphism, the cells seem to be geographically close together. It's not like a random atypia, for example, that you might see, like, for example, like in low-grade myxofibrosarcoma, the atypical cells are sort of randomly scattered throughout the whole tumor. Whereas in this, there is some geographical clustering of the pleomorphic cells. Again, what that means, I'm not sure, but that could be the very early start of progression. You know, if progression does occur in these tumors, perhaps this is an early mechanism.
Thank you. Any further question or remarks?
Well, I just would like to share my experience with this kind of tumors. We have 3 cases, but one of the cases was more mitotically active than the others. Most of them were almost 1 or non-mitosis. And the third one was around 6, 7, 8 mitosis per 10 high power fields. But the tumor in the biopsy was not mitotically at all. And in the surgical resection, there were these areas with higher mitotic rate, probably related to a transformation in a more malignant thing. And that was what we suggest, but it's difficult to work with this kind of tumors that are few described in the literature and we have very few knowledge about.
Yeah, no, it's a good point. Yeah, that with the mitotic activity, yeah, I mean, here, I guess the papers that have been written on this, they really do stress the low mitotic activity. I guess you could almost see it as being definitional for the diagnosis. If it had increased mitotic activity, I guess you might be a bit more worried, particularly then trying to separate it from things like spindle cell rhabdomyosarcoma. And whether the increased mitotic activity is a form of progression to frank sarcoma, again, I don't know if anyone really knows that. It's interesting that some people have raised the possibility that the things that we call pleomorphic rhabdomyosarcoma in adults obviously no one really has looked very closely to see whether some of those could have originated from what we're calling IRT. So it is possible that IRT is the precursor for some of these pleomorphic rhabdomyosarcomas. But yeah, no, the significance of mitotic activity in this setting, I don't know, I think more study needs to be done to see what happens if the mitotic rate is elevated.
I have a question, because when this entity was described, they talk about the co-expression of neogenic markers and histiocytic markers in the tumoral cells.
Mm-hmm.
And do you have any information about what happens in spindle cell or pleomorphic rhabdos with these histiocytic markers? It can it be helpful for differentiate between this entity and other rhabdomyosarcomas?
Yeah, no, I think that's a great question. Yeah, look, to tell you the truth, like you, I'm a little bit skeptical about the utility of that, because I think, let's face it, if you do histiocytic markers in sarcomas and in smooth muscle tumors, more often than not, you see tons of them in the background. And, you know, I think from time to time, we get cases sent in to us for consultation where someone has a sarcoma and they can't arrive at a diagnosis, or they're not too sure how to categorize it. And someone has done a histiocytic marker and the slide is brown. And so they propose, could this be a histiocytic sarcoma? And there's always that challenge of trying to figure out, is it the tumor cells that are staining, or is it the histiocytes? Are they the histiocytes in the background? But I think you're right, you know, that if you were to do it on other types of rhabdomyosarcoma, not that I've done it, but I suspect they also have a lot of histiocytes in the background. But having said that, when we did it in this case, it was in some areas, it was very strong. The histiocytes seemed to be almost clustering. And it was different to just the diffuse infiltrate that you see. So in some areas, you can see the histiocytes almost loosely aggregating. Our case was a little bit different to the ones that have been classically described in the literature, because the ones that in the original paper by Andrew Fulp, he emphasizes that the histiocytes are morphologically very obvious, which is why originally they called this histiocyte-rich rhabdomyoblastic tumor. I think since then, people recognize that the histiocytes don't need to be that prominent, and you can have other inflammatory cells. But I think in the classical example, the histiocytes are obvious, even histologically. And in some cases, they make the point that the histiocytes can be so prominent that it can overrun the tumor cells. A bit like, for example, in inflammatory myofibroblastic tumors, sometimes the inflammation can be so dense that it's hard to see the tumor cells mixed in with it. So I think in response to your question, I think you're probably right. If you did a histiocytic marker in other types of myogenic tumors, you'd probably see it a lot. But in this case, in a classical example of IIT, you would probably see the histiocytes even histologically.
Thank you very much.
Thank you, Daniel. So any further questions or remarks? So thank you very much, Daniel, for your time and for your nice presentation.
No worries. Thanks for the invitation again.
Thank you. We continue with our last speaker, is Dr. Empar Mayordomo. She's attending pathology and section head from pathology department of Vital La Fe from here, Valencia. Empar areas of interest include bone and soft tissue tumors and hematolymphoid pathology. So Empar will share some areas. She's an active member of IMPERAS projects, and she has also a contribution in soft tissue pathology. So Empar, thank you for your time, and please, could you share the screen and start your presentation?
I thought I was sharing already. Can you see it or not?
No.
Not really?
No.
Oh yeah. Now? No, sorry.
Yeah.
Okay. Good morning to everyone. Thank you very much, Isidro and Cleo, for organizing these meetings. I think they are great. It's a good time to share our cases and our knowledge, and it's a great pleasure to share today with the speakers that preceded me. So I'm talking about a case we had is a 56-year-old woman who came to our institution to perform a complex surgery, thinking of a peritoneal carcinomatosis. So as a previous medical history, has only had an sclerosing stromal tumor at the ovary, which was in theory cured. As you can see here at the images, a CT scan and MRI was performed.
Sorry, there is not forward the slide. Ponlo en la copita para que salga completo.
Sí, es que, a ver, yo lo estoy viendo, pero a ver.
Ahora,
Now?
It's good better to put the full view.
Yes, but I
if you press your slideshow button, just where your arrow is, just go down and hit the slideshow button. So keep going down.
O en la copita de abajo, Empar, para que lo pongas en completo.
En la pero la copita de abajo yo no veo, a ver.
A la derecha.
A la derecha.
En el PowerPoint.
Sí, sí, en el PowerPoint estoy, pero...
Puede ser que estés compartiendo una cosa y no la otra.
Compartiendo otra
O sea,
pantalla.
tú puedes compartir la pantalla entera o puedes compartir una página concreta. Igual estás compartiendo.
Uso compartido de pantalla. A ver.
Selecciona la pantalla entera y entonces se verá todo lo que tengas en la pantalla.
A ver, voy a intentar. ¿Otra vez? ¿Así?
Deja de compartir esta y comparte la que tienes ampliada.
Si quieres, deja de compartir y vuelve a compartir en paz.
A ver este. ¿Mejor? ¿No?
No.
Ahora tienes que dejar de compartir.
Ahora sí.
Ahora
sí.
I'm sorry. I had from the beginning some technical problems. So
Don't worry.
I was saying that, as you see in the radiological studies, you see many different tumors that are in the abdominal cavity, also pelvic space, and also retroperitoneal in between the intestinal loops. And the radiologists describe as a lipomatous nature, also necrotic and hemorrhagic. It's not working? Ahora no se me echa.
No.
Wait a minute. I think I'm gonna change the computer just in case it's my computer.
Empar, ¿quieres que intente yo compartírtelo?
No. Si en algún momento me aclararé. Vamos a ver. A ver ahora, espera.
Abre primero el PowerPoint y después compartir.
Sí, eso es lo que estoy intentando, pero claro, como está ahí, a compartir, es que hay que darle el compartir. ¿No?
Vale, ahora sí.
Okay. Okay, let's see if it works this time. Sorry.
Ahora sí.
No, okay. So I was saying, yes, large tumor, but multiple nodules separated, but involving the intestinal loops. So in theory, this was assigned to the gynecological pathologist. It was operated by gynecologists and general surgeons. But when they saw this piece, so they called us, my colleague, Dr. Giner, and I, to see, this is not a peritoneal carcinomatosis, this is a lipomatous tumor, soft tissue tumor, no? So this tumor is yours. So as you can see here, this is not completely what we see in a retroperitoneal tumor, that is a large masses, adipose tissue, heterogeneous. There was like a enlargement, general enlargement of the omentum, with different masses, also pedunculated masses pending from the this omentum. So some of them were, yes, adipose, but other were very like cystic, not cystic, but edematous. And some of them, as you see here at the bottom, fleshy and whitish, and others were cystic with hemorrhage and a little bit necrotic. So, so what do we have to think when we're dealing with soft tissue in the abdominal cavity or retroperitoneum? This is for trainees. No? So first of all, carcinomatosis, what they expected, but it's much more common. But in second, I think we have to think indeed the differentiated liposarc. It has many phases, and I've assisted to many talks that say, first of all, rule out the differentiated liposarc and then carry on with the diagnosis. No? So if we see the morphology, all the tumors look the same. We didn't have this abrupt transition between an adipose tissue or recognized tissue and other sarcoma. So the first side, we didn't think in the differentiated liposarcoma. So the tumors include heterogeneous areas, very edematous, not myxoid in the background. The Asian blue was negative, and also with cystic spaces that were in between. There was a kind of zonation. We're gonna be see in detail. More cellular areas were surrounding vessels and surrounding these empty spaces that you see here. Also, the vascular background was important. Sometimes it looks like a myxoid liposarcoma, but other times were more mature capillary network. In some areas, it was very difficult to recognize who were the neoplastic cells. There was an admixture with inflammatory cells, mainly chronic, so small lymphocytes, as you can see here at the screen, and plasma cells, and also pigment was there, so hemosiderin. So here we see like a pyogenic granuloma, so with capillaries and all this mixture of cells in between. And other areas that were more cellular where, yes, we recognize that's a population that is growing. So they are small cells in the background, which are in our opinion, they are the neoplastic. They are small, kind of epithelial, kind of fusiform. They were monomorphic, very low mitotic ratio. Here you have a mitosis, but we could count only 2 mitoses in 50 high power field, and only sometimes we see these pleomorphic kind of rhabdoid cells in the middle, no? But this was very rare, no? The main morphology was these small cells that we see in the background. So very difficult because of the presentation with multiple tumors. Also the morphology that is quite blunt, edematous, small cells, epithelioid. So I don't know what you think, but we had many different diagnoses in mind. So myxoid liposarc because of the background and this these vessels. They differentiated because of the frequency in the area, but actually we didn't see these two phases. Why not a well-differentiated liposarc, the inflammatory subtype, actually kind of inflammatory myofibroblastic tumor, because it looks like very inflammatory in the background, or always in between these small round cell tumors that are a typical presentation that have this B-core or SIG rearrangement. And of course, we have to pay attention at the history of the patient, no? So in theory, sclerosing stromal ovary tumor is a benign tumor, is a sex cord tumor that is usually is very rare, any age, and is located at the ovary. And once it's removed, the patient is cured. but I don't know why not. Is a relapse, or during the surgery they break the tumor and they implant in many. It was at least to keep in mind. And when we review the cases, of course, that's the problem that we share. We are subspecialized, no? If I don't see the sarcomatous gynecological tumors very often, so when I have, or when I deal with one of these, I think it's more difficult. And so it can also to in the differential this kind of tumors, no? Although the presentation was not, they didn't favor this a relapse of this tumor, because as I said before, is a benign entity. So, but we include in the inhibin and calretinin in the differential, in the panel. This is a review that we use that can be very useful for trainees to a start point to face these retroperitoneal or abdominal tumors. So it's a wide panel of immunohistochemistry that may include MDM2, CDK4, also muscular markers. The leiomyosarcoma is the second most frequent in retroperitoneum, although it doesn't look like this. So other markers that are always to keep in mind, so S100, HMB45, it could be apicoma because of the morphology, although they are very small cells, but also because of this pigment that we know that is hemosiderin, always keep in mind melanoma, no? So they are always included. Obviously, cytokeratins or epithelial markers, because it was presented as a peritoneal carcinomatosis, so we do have to exclude this option. And also because of the presentation, it could be a kind of a mesothelial tumor that is growing in many different points. Other tumors that are usually multicentric and in abdominal, that are, for instance, the desmoplastic small round cell tumor, which also was good for the presentation, but not good in the morphology. Usually they more round cells and bluish, and the stroma is more hyalinized, but also keep in mind, I don't know if you have, we will comment later if you have an idea only from the morphology, but I didn't. So I ordered all these immunohistochemistry. The most relevant markers, they were positive, were the muscular markers, and we couldn't expect that because it looks like a myofibroblastic a little bit, no? So was desmin mainly, very intense and diffuse, and only patchy, the smooth muscle actin and calponin, I will show in a minute. And we also included WT1 because of the mesothelial marker, and also for other stromal, sexual cord stromal tumors, and it was positive. We included in the differential because of this immunosuppression, the microcystic stromal tumor, which doesn't look like exactly as ours, but is very cystic and very very blunt, and it could be also in the differential, but only sharing with ours the WT1 positivity, because it was beta-catenin and cyclin D1 negative. So these are the markers we have. Here you have the desmin positivity, WT1 also positivity, negative for all epithelial markers. ALK is negative, and BCOR also, another that we said before. And then the patchy positivity with smooth muscle actin, and higher with the calponin. So what would we do next? Do you already have a diagnosis? Well, if you have, and you say in the chat, I will send the next case to you. No? So what could we do? Well, the first thing is include more tumor to study, because the radiologists say there were necrotic areas. We haven't seen these necrotic areas. Of course, I haven't shown the whole tumor. There were these hemorrhagic areas. can we get the previous tumor? What happened with this resection? Because we weren't told at the beginning, but they removed not only one ovary, but both ovaries and the uterus. We couldn't get this tumor, and the report of this resection was that this diagnosis, as I said before, and nothing at the uterus or no malignancy. Order more immunohistochemistry, because if we're dealing with, or at least we would to rule out something gynecological, we have to order now. So hormonal receptors, so estrogens, progesterone, and CD10. Also, we order Vimentin. And we can perform molecular biology to exclude the diagnosis we thought at the beginning, because when they say this case is yours, that means we have to rule out other entities, sarcomatous entities, and at last send the case in consultation or share the case with someone that knows better than you. That in our case is Dr. Yombart and Isidro, that we share cases together with Dr. Giner every week, and is very, very helpful. So as in an exam, all the above could be right. So and we re-include more pieces of this tumor, and here in the morphology is the clue. We've seen at the intestinal wall that there were, as you see here at the right side, there were endometriosis implants at the wall of the intestinal wall. And also the cyst I told before, inside these nodules, they have some lining in some of them, no? Or lining, sorry. Some were pseudocysts, but others had the lining of a cylindrical ciliated cells, which were not peromorphic, but remind us this endometriosis, or this endometrial layer, and also this concentration of the cells around this epithelium that could be also a part of very important for the diagnosis. So now coming in between the thought of what about being a low-grade endometrial stromal sarcoma, but related to this endometriosis foci, no? Because if the uterus has nothing, so it has to be directly from here. Or keep in mind, so it's not soft tissue tumor, but a sclerosis stromal tumor with different, I don't know, with more malignant presentation. So we performed this extra immunohistochemistry. They were very intense in estrogens and progesterone, and only patchy CD10, which usually is very strong in the stromal endometrial stromal tumors, sarcoma. Sorry. Vimentin was very positive, and also muscle markers go for it. So we also performed other FISH, because we had already performed to exclude other sarcomas, MDM2, ALK, and EWSR1 that were all negative. We also send the case to, well, we perform NGS, and we send the case to the Hospital Clínico to do other fusions that are usually present in the low-grade endometrial stromal sarcoma, which are just F1 fused with SUS12, and they were negative. Also high grade, just in case we are underdiagnosed, because the tumors were quite large, between 1 centimeter till 13. No? So we didn't want to. The morphology was low grade, but we didn't want to miss anything. So we couldn't perform this fusion between GLI2 and FHL. To really exclude this previous tumor that had the patient. And we performed the NGS for oncoma in childhood to exclude other fusions that we didn't, that we could miss, which was included also the FOXL2, which is positive in ovarian tumors and endometriosis, but it gets also negative. So, at the end, we diagnosed the case as a low-grade endometrial stromal sarcoma associated to multiple foci of endometriosis. That is already written and described in the literature. I would like to know your experience about that, because we had no experience before. But what we have to pay attention to this kind of endometriosis that is called micronodular, that could be only a stroma in the implants with no epithelium, that probably we also have. They can be atypical. The most frequent change to atypical or to malignancy is epithelial atypia and overgrowth of this epithelial into a carcinoma. But it is also described that the epithelium is non-atypical, as in our case, and the stroma is what is growing, so as a low-grade endometrial sarcoma. So this is what I wanted to share with you. I thank all the people we work in a daily practice in sarcomas, and all the audience from hearing. And I will be very pleased to attend any question. Thank you.
Thank you very much, Empar, for this nice presentation and this very difficult case. So this is very difficult. So I have a question. Is there any possibility that this previously tumor diagnosis in the ovary as sclerosing stromal tumor was also endometrial stromal sarcoma arising in ovarian endometriosis? Low grade?
Probably. That is the problem with some private hospitals here, because this is something to work with. We cannot get the tumor, so it would be very nice to get the whole piece. And they say they don't have the blocks, so we only could get this. But they also said a standard that the inhibin and calretinin expression was only patchy, and not other immunostains were performed. So our hypothesis is that probably this could be the same as we've got now.
Does anyone have a question? Empar, please, could you stop to share the screen? Okay, thank you. Any question, remark, comments? Professor John Barr, Akihiko, Daniel?
The patient is doing well now.
All the
He's in control and is doing well.
Congratulations, Empar. It's a very nice case, a very difficult case, really. I never came to such a diagnosis. Congratulations.
Thank you. Yeah. Now we're sharing more cases with my colleagues from gynecology in order to have this view of the stromal tumors. No? So I thank Dr. Montero and Lopez Agulló also for sharing the cases, also with in the mama, no, in the breast pathology.
That means they need to be more general pathologists when facing tumors. You see, super specialization is also a problem now, because we don't think so much another type of neoplasms seen in places like ovary or the endometrium, when we are looking to tumors in the stroma or in the peritoneum. That is for trainees, it's necessary to have a very wide view of the pathology, of the tumoral pathology, in fact, and inflammatory too, as we have seen in the former cases. Thank you, thank you.
Or team working, team working.
Any further question? Remarks? No? Okay, thank you very much, Empar. So many thanks to all guest speakers and attendees to participate in this session. We have really enjoyed with your case presentation. I hope to see you again in a future session. Just to remind that the next session will be June 16 at 30:30, because there will be speaker for USA and from Spain. So looking forward to see you there. A special thanks to Akihiko, Daniel, and Irene, because there is 10, 9, and 8 hours ahead. So we really appreciate, of course, also thank to Empar and to all the attendees. So I will send you the recording if you wish, and have a nice day, and thank you very much. Bye-bye.
Right.
Bye-bye.
Thank you. Thank you for having
Thank
me.
you.
Thank you.
Bye bye.
Bye, everyone.
Bye.
Bye.
Foto desde la pantalla.
Mhm.
Uy.